We've reached a period in terms of the ability to generate patient data, to aggregate it, and then to interrogate it in a way that has never, ever been possible. Combine that with a whole range of technologies relative to genotyping. Foundational breakthroughs have been enabled, and now add in generative AI. It's stunning and maybe a little sobering just to think what's possibly just a few years away.
Welcome to Unnatural Selection, a show about competition, innovation, and the strategies shaping tomorrow's frontiers. I'm Nick Encina. Each week, we speak with pioneers shaping the future.
This is episode number 5. Today, we look at innovation inside one of the largest and most complex systems imaginable: academic healthcare. MassGeneral Brigham isn't just big, it's essential. And when institutions reach this scale, adaptation becomes harder, slower, and more fragile. Yet the pressures don't stop. Science moves forward. Technology accelerates. Expectations rise. In this episode, we explore how innovation survives inside a system built for stability. We talk about how research becomes real-world impact, how new companies are born from inside hospitals, and how emerging technologies are forcing even the most established institutions to rethink how they evolve. This is a conversation about keeping something irreplaceable alive. Our guest is Chris Coburn. Chris Coburn is Chief Innovation Officer, MassGeneral Brigham, an integrated healthcare system that includes Harvard University affiliates Brigham and Women's Hospital, Massachusetts General Hospital, Massachusetts Eye and Ear, and McLean Hospital. MassGeneral Brigham is the nation's largest academic research enterprise, with over $20 billion in annual revenue, 1.5 million patient visits, and more than $2.9 billion in research expenditures. It also has a managed care organization, outpatient facilities, and community hospitals. 7,000 of its faculty are appointed at Harvard Medical School. A member of the senior leadership team, Coburn is responsible for the commercial application of the unique capabilities of MGB's 82,000 employees. His 140-person business development group's activities include strategic industry collaborations, company creation, investing, translational development, commercial strategy setting, licensing, and innovation management. His group also manages a nearly $500 million venture fund. Prior to joining MassGeneral Brigham, Mr. Coburn was founding director of Cleveland Clinic Innovations. During his tenure, Cleveland Clinic spun off 57 companies that raised more than $700 million in equity financing. Previously, he was vice president at Battelle and served on the staff of Ohio Governor Richard Celeste. Mr. Coburn serves on multiple boards. He and his wife Nancy have 3 grown children. Let's go.
Chris, it's a pleasure to have you on Unnatural Selection. Thank you for being here.
Hey, Nick, thanks for having me. It's really great. Just 2 quick corrections. 2.9 billion is the level of research activity for us. And then also we're up to about 2.6 million patient visits. But again, thank you for having me, and look forward to talking.
Perfect. Thank you. So I start with the same question with everybody, just because we can't assume what the listeners know. And also, for as much as I am a part of the MGB system, I also may not necessarily know in detail what MGB sees as its core business. So if you could, Chris, could you tell us what is the business that MGB is in and what your job is within that?
I appreciate that question, especially in this time, tumultuous time in healthcare overall. I would say I would describe our business in 4 categories. Obviously, it's to treat the sick, try to make people healthier. 2, to do research, as you referenced. 3, to teach, and 4, to benefit the community. If you go back to the founding of the original piece of our system, Mass General Hospital, in 1811, I think those aspects have basically always been there. So there's been a continuity in terms of the priorities of why we exist as an organization.
Yeah, it's interesting we start there, right? Because obviously the basis of this podcast and blog is that look at incorporate innovation through the lens of natural selection and think about how we can find parallels across those things, which I've experienced in multiple fronts, whether it be biotech, technology, or healthcare. But if we look at MGB, so Mass General Brigham, MGB short for those of us that are familiar with it, it's the largest hospital-based research enterprise in the U.S. and it's constantly evolving. And generally speaking, the larger the organism, the harder it is to adapt to environmental changes. Like as opposed to startups, they're like
Yeah,
constantly
yeah.
pivoting and adapting. And yet, when we look at MGB, it's undergone huge changes over the years. You mentioned its founding, and in the 1800s, the hospitals, MGH, Mass General Hospital, and Brigham and Women Hospital. In 1994, they joined forces under Partners Corporation. 2015, there was a major disruption with EHR implementation and overhaul, electronic health records for people not familiar with that. And in 2019, just before COVID, Partners rebranded as MGB, Mass General Brigham. So when you think about these evolutionary changes, many of these, actually all of those really being intentional, and then you think about kind of like the disruptions that you perpetually experience, whether it be tech companies, retail entrants, COVID, and most recently, the federal government's 15% cap on indirect costs for some of the grants, especially from the NIH. How you're in this position where I want to ask, it's a loaded question. It's I'm sure there's all kinds of different variations for it, but how do you balance reacting to all of these disruptions while simultaneously innovating for MGB's future competitiveness?
Uh, there's a lot wrapped up in the points you just covered. So let me try to unpack that a little bit if I can. Um, First of all, as you said, in terms of the focus of unnatural selection, your podcast, I think it's interesting when you look across industries relative to innovation. To me, a common denominator, if not the common denominator, is organizational innovation. It's what enables the technologic or even the scientific to emerge from that. So when you look at us, that long sweep that you just went through, and Mass Pioneer is celebrating their bicentennial. So literally centuries of looking after the sick and doing some incredibly important breakthrough science. Um, but but again, it's how things are approached, how things are enabled, um, and so if you try to look at us as I think you're doing on the podcast, um, this this top level of the organization, what's going on there? Well, we're essentially delivering a product. We are treating people. We're providing a service, and in doing that, we absorb a lot of technology that starts elsewhere, and then part of what occurs is that technology gets adapted to fit our needs. So, to me, that's a very interesting question. So, one of the things we did in my shop, you're working with system leadership, was to create a small investment fund that is focused on digital and AI innovation that starts out principally outside of the four walls of our system. And it allows us to partner in a very meaningful way with the companies, maybe more than would otherwise have been available if we were just a customer. So, a set of companies have been invested in. A bridge we could talk about is, I think, a great example of the early impact of generative AI in healthcare. A Bridge's initial focus, ambient documentation. They have a fantastic product. We have 800 users in the system, clinical users in the system now. It produces a note, and as you said, the Epic compatible note that is in the hands of the clinician within 1 minute of the conclusion of the patient encounter. And and other companies have also have that. and we work with those other companies. But I'm talking about a bridge because we're also an investor in them, and that created a special kind of relationship. A different company, DexCare, was spun out of Providence Healthcare in Seattle. It's a scheduling and load leveling, or initially technology, and so important in terms of access to care. As a topic for your priority for Ariadne, and that is partly technology and innovation enabled. And then finally, going a different direction, and going into another one of our pillars in terms of organizational um, uh, mission is a company called Amplifier that has some really neat technology that drives the learning drives learning to a higher level, and they focus on a really interesting. Their initial point of entry is on uh, um, I want to get their terminology right. Uh, uh, strongly held, not strongly held misinformation. Uh,
Hmm.
and kind of interesting, that particularly in healthcare, how people acquire an intensity around a set of feelings that are just wrong. And I personally associate this often with sports and sports discussion when you're talking to people, but it can be life or death in healthcare. So understanding how that happens and how to break it down and how to restructure what resides in someone's mind, it is really quite important. And Amplifier was created to address that. So just some examples of how we try to look beyond the capabilities that exist within the system, but understanding that as us as a user, and then frequently an enhancer of technology that's developed on the outside. So a long answer, but that is one example of innovation in our broad and diverse organization.
Yeah, no, that's great. And you obviously kicked off a great conversation around organizational innovation, right? And organizational evolution. From that perspective, MGB is like the parent corporation over these massive hospitals, and both of them, well, all the whole health system is incredible. MGH and Brigham and Women are consistently the best, some of the best hospitals in the U.S. and in the world. So when you talk about innovation and incorporating these innovative products into your workforce, how do you balance kind of like um, a cohesive, system-wide approach to innovation while also retaining the individualistic approach that each hospital might have?
Yeah, great question. I think that it cuts right to the core of academic medicine, which is, uh, it's one of the most rigorous, if not the most rigorous, category in the U.S., really the global workforce in terms of being a healthcare provider. And at least in my mind, uh, essentially every one of those people, whether they're clinicians or nurses or full time in the lab, uh, are sources of actionable innovation. So it's kind of on us, in the central organization, to help to equip them and, create the approaches, the policies that allow their insights to flourish. So it's, an interesting thing to jump to a specific area. So if you talk about working with industry, so, not just innovation in general, but things that are going to result in a product, ideally outside of the organization. So you had said earlier that our 7,000 Harvard appointed faculty, um, only 5% or 6%, depending on how you cut it, of our faculty are involved in innovation that then results in something that expresses itself in the commercial realm. And if we as an organization exist to better the lives of people, the broader that aperture, the more we address why we were created in the first place. So in my mind, we want more innovators. We want to equip them better, And so we have a whole set of programs which I'm happy to talk about in terms of ways we try to grow, the scale of our innovation workforce and then to equip that. But the key point to us is the delivery of care. Again, going back to what we were saying a moment ago, the delivery of care itself creates an opportunity for innovation. And the thing about a hospital that's different than a company or different than a university is, the sacred moment of that patient interface is occurring, within our organization. So the opportunity to learn from that and ideally enhance it presents itself every day. And so, unlike even the best and most successful companies, where they have to go to a third party typically to gain clinical insights, that's part of our day job.
Yeah, no, it's fascinating. And you bring up the workforce, and obviously I can't help but bring up implementation science, given that, I've been at Ariadne for such a long time in Harvard School of Public Health. Um, so, innovation, it's interesting, right? Because it's so much is happening these days. I mean, I talk about all the time how we're in this hyper innovation, time, especially made available through the internet and cloud computing and now AI, which it feels like even those of us in the industry, it just feels like every month is different. There's something new. And as consumers, it's hard enough to keep track. As an organization, it's almost impossible to know where do you invest, what do you apply, what do you implement, what do you look out for, what do you ignore. And then to add a layer on top of that, health systems, which I'm very familiar with, they can only sustain so much adoption of innovation, right? It's just like you just can't bombard them with stuff because doctors are getting hit by vendors. You're coming up with your own innovation internally. It's just constant stuff going on. So you kind of have to like bet on specific horses every year. And some of those projects might actually take multiple years to implement and unroll and roll out and train people. Um, so with all of these things in mind, and I know your job is very hard because you're at the crux of all that, how do you think about all these different innovations coming at you at this speed, and then what you're trying to do internally, all of that in context with how quickly the health system can absorb those innovations?
Yeah. I think of it as managing dynamic tension. So essentially you're talking about two different curves and trying to optimize the point at where they cross over and or maximize the space underneath those curves. And and I don't want to overstate my role or anyone in central administration. Y- y- You know, it, the buyers, if you will, of external innovation are throughout the organization, as you know from Ariadne. Um, so those people themselves are, if you will, arbiters of innovation. I think in Central, we're talking about, again, creating the environment, trying to ensure that there's necessary resources at the individual level, as I was saying before, enabling and hopefully guiding uh, uh, leaders and folks within the organization who might be innovators. So that um, again, it's maybe I would say different than I used to be pretty active, even going back to when I was at Patel in the Industrial Research Institute, which was fascinating because you had all these different industries there. And then more recently, since I've been at MGB, a couple groups that are national that also involve multiple industrial segments. And again, this question of what are the transcendent issues, at least from my travels, brings you back to these, how are you best organizing and directing and equipping your team to be able to do it. So I, we're not so much in as you might be in an industry setting strategic innovation targets. We're more organizing and equipping. So to try to make that clear, our office spent several years getting the Gene and Cell Therapy Institute organized and launched at MGB. And, a terrific team has come in to run that. A cardiologist named Roger Hajar runs it. Roger spent many years in academic medicine doing gene therapy, and then more recently was at Flagship Pioneering. Um, and, a person really ideally situated to provide that hands-on leadership. So stepping back, the role of Central in this was to recognize the theme, the opportunity, do the research. For instance, over 400 faculty in the system are doing work in gene therapy, cell therapy, gene delivery, and associated things like software. And that's actually growing. I think if I remember right, about 500 million in total research support going to those people. So an area of opportunity and if you will, a patient need. So many unmet needs that might be addressed by those technologies. So for us, just going back to kind of the broad organization, setting that theme and building the entity and then bringing in the right people to run it was our job. And more recently, we've been working on behavioral health opportunities in a similar way, including things like psychedelics. But I hope that makes sense. We're not a company. We're not by ourselves, or we're not bringing in consultants to say these are the 5 or 10 most important areas. We're uh, working with the faculty, shaping themes that then we can construct capabilities around.
Yeah, that makes total sense, and it definitely resonates. I mean, it's not like ultimately you do build products with your collaborations and so on, but your business is not to create products. I mean, your business is to deliver proper health. And so what you're doing is strategically looking at where the 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 patterns are and the discoveries are in science and healthcare and saying, okay, where is this field going to be in 5 or 10 years? Because to construct something like what you just said, it takes a while. I mean, from identification to planning to resourcing, all the way to building it and staffing it and launching it. It's a 5, 10 year effort, I would imagine.
Well, yeah, several good points there. I mean, one, again, thinking about, what businesses are you in or not in? Uh, First of all, no university, no hospital was ever established for commercial outcomes, which is a point you just made. But the way I think about it, we do exist at both ends of the spectrum, where discovery science is occurring in abundance, and patients are being treated. So that, the classic bench to bedside and back characterizes us, but we don't fill that whole gap. Partners, collaborators have to exist to take those benefits forward. And so, it's just interesting to think about it in that way. So it's this question of again identifying areas that can become priorities, even though if you were to create a map of where the strengths are for our faculty, I guess I would say a thing that characterizes us is that breadth. And as you mentioned, I worked at Cleveland Clinic for a long time. The level of research that we have is more than 7 times, and maybe up to 8 times what Cleveland Clinic is. And that's not to say that what happens at Cleveland Clinic is not world class. It is, but it's heavily in cardiovascular as one area of real capability versus us where it's so broad. So now, if you think about that in terms of future planning, in the last 10 years or more, cancer was the hottest area of innovation and investment in healthcare. And more recently, neuro has come back. It was kind of in a long winter, and cardiovascular drug development, partly driven by GLP-1, has also rebounded. So it's kind of interesting to see those broad curves, and then say, okay, what are the assets we bring, the people, the technologies that will help us to be in front on those.
Yeah, it's interesting. You said a bunch of things that are really interesting there. I mean, when well, one of the things you said was interesting. You're getting back into neuro. Like you said, the long winter. Biotech it was for a long time divesting from neuro. And so, do you see that a resurgence around the
Yeah,
neurological space?
I don't want to overstate that, but at least where I'm sitting and what we're seeing, yeah, it is picking up. I think, you know, insights on neuroinflammation have fueled further steps. Progress, obviously, including on Alzheimer's, I think has brought back more folks from the sidelines. But it was a long go, and it's exciting. I mean, uh, one of the reasons I enjoy working here is working at Mass General Brigham is there's just so many top tier scientists, clinicians, and just people in general that are committed to diseases like Alzheimer's or MS or ALS, and are doing some of the best work in the entire world. So pretty neat that it's all in largely in the same organization.
Yeah, I mean, and just to be clear, my enthusiasm was exactly that. I mean, it's such a necessary space, the neurological space, when you talk about things like Alzheimer's and other diseases, yet it's such a complicated and difficult scientific space. So that's why, for those that aren't familiar, that's one of the reasons why pharma was divesting. It wasn't because there isn't an opportunity or a massive market. It's more because it's just a very, very difficult space to do something significant. So I was encouraged and excited when you said that MGB is getting further back into that.
Yeah, and if I were just to reflect on my time at Cleveland Clinic versus Mass General Brigham, if you think about it as, let's say medical device innovation versus, biotherapeutics, a beautiful thing about, let's say, a cardiovascular medical device, TAVR, it gets conceived, gets piloted, it gets optimized for manufacturing, and ultimately, hopefully gets approved and reimbursed. You can, in a sense, you can see all that. You can measure the impact. The parameters are very well established. Now, if you're talking about a drug that goes into the nervous system, goes into the brain, and you have to demonstrate in a very specific way that, first of all, the safety, of course, and then the benefit and the financial aspects of that. That's so complicated, and so anyways, it's no surprise that exit occurred, and hopefully it's going to be a vigorous period, assuming all these other global factors don't disrupt things. But I personally am quite hopeful that we're going to have a very exciting, especially as things like CAR T technology works its way into autoimmune diseases and neurological disorders from its initial beachhead in cancer.
Yeah. And just like in nature, sometimes some punctuated change kind of unlocks an entire field of evolution. And in this case, like you mentioned, some of the scientific and technological progress has made it so that companies are starting to look back into the neurological space. Things that were impossible 10 years ago or even 5 years ago, all of a sudden, like, oh, wait, hold on a second, this is actually potentially doable. And so it's exciting to see how the field is getting back into that. You also mentioned, though, kind of like the bench to bedside, that spectrum, which is notoriously difficult in healthcare. That whole translational development, which is, I know it's part of your background and something you focus on. Can you tell us a little bit about bridging that gap? For those listening, there's a lot of activity upstream in the discovery side, whether it be biotech or devices or diagnostics, what have you. And then all the way downstream, you have the point of care, where you have patients, you have clinicians, you have health systems actually implementing these things at scale. And in between, there's this chasm. It's almost in many ways kind of like a death valley where innovations struggle getting from the discovery space to actually point of implementation. In that field is called translational sciences, translational development, translational medicine, depending on who you're talking to. And the idea is, how do you translate raw discoveries into something that can be delivered at point of care. And obviously that
Yeah.
involves regulations and all kinds of things, but a lot of it is also health system preparedness and readiness and training clinicians and educating patients and all those things that involve an implementation. So could you talk a little bit, because we spent a lot of time on the innovation side. How do you think about getting that to the finish line, which is actual usage?
Yeah, great question, and obviously an enormous priority. I think it's kind of interesting if you think about Boston from, let's say, Cleveland or any other part of the country. You always you have to acknowledge the global leadership that's there. But despite that, this translational gap is present in this town just as it is all through the U.S. So I think an important thing, just as you said, is identifying and acknowledging that that gap exists, and then taking the steps to try to address it. And for us, that means a few different things. One, we established in 19 and have grown it since then, a translational investment slash development mechanism, a set of programs that allow us to assist. Once a highly promising technology has been identified, it's always preclinical to drive it forward, to do the added work, and even to get it into the clinic. And this is a set of capabilities we recruited in a handful of people from industry specifically just to work on this. And then we've actually have some financial resources to work with as well. So by and large, we're mimicking what might occur in industry while it's still within the organization, which is important for a lot of reasons. Obviously, proximity to the caregivers, to the original innovator, um, but also from even a regulatory standpoint. When the technology is still in the academic center, in the clinical setting, it can advance much more quickly and usually at a much lower cost than if it's out into the commercial realm. So this gives us what I think is really a unique opportunity to enhance, to validate, to at times modify the technology, but most importantly to accelerate it to get it to patients. So we have a set of technologies that have worked through it. We have one large program and a few smaller ones, but all are on the same theme of providing the expertise, the industry knowledge, and the resources necessary to make that happen. And some other academic centers have a similar approach, and I'm a big fan in the ability to learn from peers. And when we launched this program, we had done very in-depth benchmarking of best practices. And, now I'd like to think that our programs, our flagship in this, we call Amplify. Uh, uh, I'd like to think that that's a national best practice.
No, that's fascinating. And eh, as we've spoken through this conversation, MGB and the hospitals within it are pioneers in so many different areas of healthcare and medicine and so many other research and so on. And in a big way, MGB and its affiliated hospitals have been a cornerstone behind this exceptionally dense healthcare ecosystem that's here in Boston, right? I mean,
And
we talk about the elements of Silicon Valley or the Bostons and so on, but it's hard to understate or overstate how this combination of healthcare, world-renowned healthcare systems, world-renowned universities, venture capital, startups, technology, and so on. This mental capital of diverse skill sets, all within. I mean, I don't know how big Boston is, but it's not big. We're not New
yeah,
York.
yeah,
How does all
it's
of that
that's
factor
so
into?
yeah,
uh,
that's so true. And I got to say, just to jump in,
Yeah,
um, e- uh, you know, being in Boston dozens and dozens of times before moving here in 2013, and also growing up from the time I was an infant
going to Cape Cod. I felt like I knew the town pretty well. My wife's father's family is from Boston, but there's nothing like being on the ground here, being on the team, and then walking, world-class institution one after another. And I think it doesn't exist like that anywhere else in the globe, and it might not exist like that at any other time, over half a millennium. A
Yeah.
millennium. It is just stunning, and a simplistic way to think about that, but I think it's yet still instructive. Some folks, particularly in the venture community, like to talk about Boston as kind of Hollywood. And if you stay with this analogy, Hollywood is a small little town, it's appended to a much larger community. Yet over the decades, every single skill needed to, produce films of significance has come to rest in that small little geography and has flourished now for decades. Now the movie industry is in another period of change, but I think that holds up for us. That a beautiful thing about Boston, that's certainly not true in other cities where I've lived, is everyone you need, every tool to make a successful company, whether it's biotech, diagnostics, um, devices, and even digital. In most categories of digital, is present. And oh, by the way, you probably don't even need to get in your car to. And I can't say that in certainly the Bay Area or Chicago or even New York. I mean, the New York biotech scene is a little more spread out. So it is something truly special. And I hope for the sake of, every patient on the planet that it stays that way long into the future.
Yeah, no, it's exceptional. I mean, I've been in Boston now for 25 years, and it's been amazing seeing the development. I mean, the seeds were already there, but they've just kind of blossomed in a way that I couldn't possibly have imagined. In the interest of time, I had two more questions, but I'll actually merge them into one. With everything we've talked about, I'd love to know what you're most excited about the future of healthcare. Where do you see the opportunities for an MGB? And then the second part of that question is for innovators out there that are excited about healthcare, doing something or want to do something, what do you recommend for them to be thinking about that future of healthcare? And in particular, how they might interface with MGB and that innovation factory effectively that you have for fostering and developing the future of human health.
Well, on the second question first, I would say, my office is all about collaboration and partnership. If you talk about, what is the base function for us, it's that. And by the way, for the sake of the audience, the World Medical Innovation Forum, we created it 11 years ago to gather industry around this idea of collaborative innovation. This year, it's September 15th to the 17th. We'd love to have folks there. Take a look at our website. So I think, we want to be as good as we can be in terms of being a partner. In terms of the future, what's most exciting? First of all, just to put it in a daily context, this is a complicated and challenging time in healthcare, particularly on the delivery end. And hopefully that, those extra challenges maybe will spur some new innovation. But um, laying that to the side, we've reached a period, as you noted earlier, in terms of the ability to generate patient data, to aggregate it, and then to interrogate it in a way that has never ever been possible. Combine that with a whole range of technologies relative to genotyping. y- you know, Foundational breakthroughs have been enabled, and now add in generative AI. It's stunning and maybe a little sobering just to think what's possibly just a few years away. And I mentioned the bridge. That's an example, but so many other things will occur. And again, in terms of progress, particularly on the digital side, but also on the therapeutic, once you reach a threshold, unless something really bad happens, you're never going back. So, every improvement in these technologies is going to lead to more and more. And so, I on my shared panels, and this is a common question. What did we think in 2015 this period would look like? And we would have gotten a few things right, but for sure, I don't think we would have been. We could have prognosticated on the availability, the growing ubiquity of course, AI, but things like generative AI as a powerful tool. So I'm excited about the future. I'm concerned about the present. It is a challenging time, and fingers crossed. But I think patients will be better off, and hopefully far better off in the not too distant future.
Yeah, no, that's a great way to end it. I do tell people that AI, for its promise and its hype, I do believe that healthcare, I'm specifically in the genomic space, those are leading edges that are seeing value today and will continue pushing those boundaries because there's actual utility and usage of AI in so much of healthcare. So this is an area to watch out for actual application of AI and the future of it.
Yeah, and then just to close, a great thing about what we do is we get to be around clinicians a lot, and even at the point of delivery of care. So you look at a horrible disease like glioblastoma, uh, things are happening right now. I can remember a while ago being exposed to being at a presentation tied to the disease. And the clinicians were saying they were viewing the progress on GBM. This thing I'm thinking about was more than 10 years ago. And they were saying that the course of care had not changed in 50 years. That essentially there had been no progress. And pretty exciting to think about where we are today. And some of that work's been done right, in our system at both MGH and Brigham. And so those are being enabled, and now increasingly those therapeutic quests are being further accelerated by generative AI.
Yeah. Well, with that, Chris, it's been a privilege spending this time with you and getting to talk to you again. We haven't spoken in a couple of years. Thank you so much for being here, and I look forward to talking to you again.
Thank you, Nick. Always nice to be with the Dayton Flyer. See you later.
Talk to you soon.
That was Chris Coburn. Now, Unnatural Signals.
This episode reveals what adaptation looks like when scale works against you. First, size creates inertia. Large organizations can't pivot like startups, but they don't need to. The ones that survive create smaller, protective spaces where experimentation can happen without being crushed by the core system. Second, discovery isn't the problem. Translation is. Research only matters if it can move. Dedicated teams whose sole job is to bridge ideas into application are what keep innovation from dying quietly inside institutions. Third, the pace of change is external. Technologies like generative AI don't wait for readiness. Organizations that survive are the ones that actively monitor what's changing around them, even when their own world has been stable for decades. Chris shows us that adaptation isn't about moving fast everywhere. It's about knowing where speed matters most.
Thanks for listening to Unnatural Selection. If you enjoyed the episode, subscribe, leave a review, and share it with someone shaping the future. Explore more at unnaturalselection.net and connect with us on LinkedIn and Facebook. Until next time, keep evolving.